In this video, we will see the disorders of phenylalanine and tyrosine metabolism. So, phenylketonuria. It's an autosomal recessive disorder. It's one of the most common inborn error of amino acid metabolism. And if you look at the incidence, it is 1:10,000 live births. And in Western countries, it is mandated that all newborns are screened for this phenylketonuria, as this disorder leads to mental retardation. So the defect in this disease is absence of phenylalanine hydroxylase. So this enzyme is not there in this condition. So this enzyme is needed for conversion of phenylalanine to tyrosine, which requires molecular oxygen, tetrahydrobiopterin and NADPH. And this is the first step in catabolism of phenylalanine to tyrosine. Apart from this classical PKU, there are other forms of phenylketonuria where it can be due to either absence or deficiency of tetrahydrobiopterin cofactor or an enzyme which helps this dihydrobiopterin to get converted into tetrahydrobiopterin, that is reductase enzyme. But we will see only the classical PKU. Biochemical alteration in phenylketonuria are accumulation of phenylalanine. Very high levels of phenylalanine are accumulated. The normal is less than 1 milligram per deciliter, but in phenylketonuria it can go up to more than 20 milligram per deciliter. So this is because phenylalanine hydroxylase enzyme is defect. So phenylalanine is not converted to tyrosine. So this accumulation opens up a minor and alternative pathway where phenylalanine gets converted to phenylpyruvate, phenylactate and phenylacetate. In the first step, phenylalanine is transaminated to phenylpyruvate. Here again the acceptor is alpha ketoglutarate and it forms glutamate. So next the phenylpyruvate is reduced to phenylactate, and also phenylpyruvate can be decarboxylated to phenylacetate. So this phenylacetate gets conjugated with glutamine to form phenylacetate glutamine. So all these, the pyruvate, lactate and acetate, they are excreted in urine. So phenylpyruvate being a ketone, this disease is known as phenylketonuria. And phenylactate and acetate, usually they give the mousy odor. The clinical manifestation in this condition or in this disorder is mental retardation. That's why very important that PKU should be identified as early as possible, because the IQ level can fall below 50 in these children. And there is also delayed milestones, and they also suffer from neurological manifestations like convulsions or seizures, hyperactivity, agitation and tremors. And they also manifest with hypopigmentation of hair, skin and eyes. This is mainly because there is less production of tyrosine unless it is supplemented. And mousy odor is also typical for this PKU because of acetate and lactate excretion. Maternal PKU. Babies born to mothers who are PKU patients and have uncontrolled phenylalanine levels, because uncontrolled phenylalanine can be a risk for intellectual disability, low birth weight, heart defects and abnormally small head size, that is microcephaly, and also behavioral problems which is seen in children. How to avoid this? We have to counsel the mother if she is a PKU patient, and we have to put her on low phenylalanine diet prior to the conceiving. Diagnosis of phenylketonuria. The goal or aim, I can say, it is early detection and treatment so that mental retardation is avoided. Apart from that, blood investigations for phenylalanine can be done. Normally it is 1 to 2 milligrams per deciliter. In PKU patient it can go beyond 20 milligrams per deciliter. Another test which is employed very commonly is the bacterial test, that is Guthrie's test. In this test, blood sample from a PKU patient is incubated with bacteria, that is Bacillus subtilis. This Bacillus subtilis requires phenylalanine for its growth. So if the sample contains high level of phenylalanine, then the bacteria grows very fast and you can see many colonies, and that will tell about the PKU, whether the patient is having phenylketonuria or not. Apart from that, we can have one more test, that is ferric chloride test, which is non-specific. Ferric chloride with urine, if you mix it, there is development of blue-green color, which indicates there is presence of phenylketones in the urine. So even though it gives blue-green color, which is transient, that is not specific. So many other compounds also give similar colors with ferric chloride. Apart from that, we have DNA probes, which usually are used to analyze mutation in phenylalanine hydroxylase gene. So we can use this DNA probes to diagnose prenatally also, that is before the baby is born itself. We can detect this using DNA probes, where we can just culture the amniotic fluid cells which are removed from amniocentesis, and we can use this DNA probes and we can detect the mutation. Apart from that, to detect the carrier state, we can go with phenylalanine load test, and if it is a positive, that shows the person is a carrier. How to prevent or manage this PKU? So prevention is not there for PKU, but early detection and treatment can prevent the CNS damage. So we can only prevent the damage which is there with PKU patients, majorly with the CNS. So all patients suffering with PKU should be put on phenylalanine restricted diet. So foods like milk, meat, fish, cheese, nuts, pulses and artificial sweeteners. This artificial sweetener is a disaccharide with dipeptide with aspartic acid and phenylalanine. So this is one compound we should avoid because these are all rich in phenylalanine. Tapioca, which is one food we can advise which has low phenylalanine content. Apart from that, we already know one of the important function of phenylalanine is to convert itself to tyrosine. So in this condition, there is no tyrosine formation. That's why tyrosine should be supplemented. That is why tyrosine becomes essential in PKU patients. Apart from that, if there is dihydrobiopterin reductase cofactor is defective, you have to supplement diet with that dihydrobiopterin or tetrahydrobiopterin, and also other reactions where this tetrahydrobiopterin is a need, for example in 5-hydroxytryptophan and L-dopa. So all these should be administered so that there is no deficiency of any neurotransmitters. And the promising is a gene therapy, but it is still under experimental stage. Coming to second important disorder which is associated with this metabolism is alkaptonuria, otherwise known as black urine disease. So the alkaptonuria, it is the first inborn error of metabolism to be identified, and it is the Archibald Gerard who described all the features of alkaptonuria, and the enzyme defect in this condition is homogentisate oxidase. So this homogentisate oxidase enzyme catalyzes the conversion of homogentisic acid to mallyl acetoacetate. So this alkaptonuria is a benign condition, and in this condition, because of this enzyme deficiency, homogentisate accumulates and it is excreted in urine. So now we know that homogentisic acid is excreted in urine. So on long standing, this homogentisate auto-oxidizes to form benzoquinones, and these benzoquinones polymerize to give a dark colored pigment called as alkapton or alkapton bodies. That is why this disease is known as black urine disease, because on standing the urine becomes or turns black. Apart from this, the alkapton bodies usually get deposited in bones, connective tissue and cartilages and give a dark pigmentation. And usually, as I said, it is a benign condition. It goes unnoticed. Sometimes in the 4th or 5th decade, the patient can come with arthritis or backache because of this alkapton body deposition in the intervertebral column at the joint space, and that we call it as ochronosis. So this is the diagram. You can see this is the intervertebral space where you can see dark colored alkapton bodies which are deposited, and they actually damage the intervertebral space and the vertebrae, thereby causing severe backache, and usually they manifest in 4th and 5th decade. So this is, you can see, a black pigmentation of the connective tissue. So this is how usually in the 4th or 5th decade the patient presents. Coming to diagnosis, already you know it is a dark urine disease. So urine color, if there is a change from black, normal to black or brown color on standing, it goes in favor of alkaptonuria. Apart from that, we can do a ferric chloride test, which also gives positive test. And homogenesic acid being a reducing agent, it gives Benedict's test positive. But do remember, if a urine is tested with a dipstick of enzyme coated with the glucose oxidase, it gives negative. So this is one thing you should remember. Even though Benedict's has come positive, your glucose oxidase test will be negative because homogenesic acid is not catalyzed by glucose oxidase, because glucose oxidase is very specific for glucose. Apart from that, we can use gas chromatography, mass spectrometry or mass spectroscopy to detect homogenesic acid. Treatment, as it is a benign condition, usually a symptomatic treatment. If they have pain and all, we can go with symptomatic treatment, and should be put on low phenylalanine diet, and high doses of vitamin C is preferred because this is one of the cofactor in the reaction. Tyrosinemia type 2 or oculocutaneous tyrosinemia, otherwise called as Rechner-Hanhart syndrome. This is also a rare autosomal recessive disorder. The defect is with the enzyme tyrosine transaminase, and usually the patients presents with skin and eye lesions. So they can be palmoplantar keratosis, something like warts, and also photophobia. Sometimes mental retardation is also seen. The third type of tyrosinemia is a transient neonatal tyrosinemia. Here the defect is PHPPA hydroxylase, and it is less serious and usually responds with supplementation of vitamin C in the neonatal period. So any tyrosinemia, the treatment is we have to put in the patient on low phenylalanine and tyrosine, and promising is the liver transplant if it is very serious. So with this we have finished the phenylketonuria, alkaptonuria and different types of tyrosinemia. In my next video we will see what are the important products derived from tyrosine and their associated disorders like albinism, Parkinsonism and pheochromocytoma. Thank you.